Namaste Betiya, Hamisha Khush Raho Betiya. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine in Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In this series, we are discussing about the diseases of the respiratory system. In today's lecture, we are going to discuss about tuberculosis. Till now, we have discussed about various diseases like bronchitis, emphysema. We have discussed about fibrosis of the lungs and various other disorders. Today, let's start with tuberculosis. Tuberculosis will be covered in 2 lectures, and it is one of the most common disease that is seen in the developing country and underdeveloped countries. Tuberculosis can affect any part of the body, but in today's lecture, we are going to discuss about tuberculosis of the lungs or the pulmonary tuberculosis. So what is tuberculosis? Tuberculosis is basically an infection that is caused by Mycobacterium tuberculosis. Mycobacterium tuberculosis is a rod-shaped, non-spore-forming, thin aerobic acid-fast bacilli. So what is tuberculosis? It is basically an infection that is caused by Mycobacterium tuberculosis. It is a rod-shaped and non-spore-forming, thin anaerobic acid-fast bacilli. Mycobacterium bovis, it is seen in the reservoir cattle. Mycobacterium africanum, it is seen in reservoir human. Around 1/3 of the world's population has latent tuberculosis. So this is a very big figure that around 1/3 of the population, total world population, is having latent tuberculosis. The disease most often affects the lungs, through the other parts, through the other organs are involved in up to 1/3 of the cases. So most common tuberculosis that we see is the pulmonary tuberculosis, although other organs are also affected with this particular disease. Mycobacterium bovis, it arises from drinking non-sterilized milk from the infected cows. So if a person is taking or drinking non-sterilized milk from the infected cows, then Mycobacterium bovis is responsible for tuberculosis in such cases. Mycobacterium tuberculosis is spread by inhalation of the aerosolized droplet nuclei. So it is spread by inhalation of the aerosolized droplet nuclei from other infected patients by coughing, sneezing, and speaking. So how does the Mycobacterium tuberculosis spread to the different individual? It is spreading by the droplet infection, droplet nuclei, from other infected patients by coughing, sneezing, or speaking. The organism lodge in the alveoli and initiate recruitment of the macrophages and lymphocytes. So these organisms, these lodge in the alveoli and initiate recruitment of the macrophages and lymphocyte cells. Now we come to the pathogenesis. What is the pathogenesis of tuberculosis? In tuberculosis, we will see that the macrophages undergo transformation into the epithelioid and the Langerhans cells, which aggregate with the lymphocytes to form classical tuberculous granuloma. So there is formation of classical granuloma. We have macrophages that undergo transformation into the epithelioid and Langerhans cells, and these aggregate with the lymphocytes to form classical tuberculous granuloma. The normal lung tissue is lost and replaced by the mass of fibrous tissue. So the normal lung tissue is lost and it is replaced by the fibrous tissue with granulomatous inflammation that is characterized by the presence of large number of macrophages and multinucleated giant cells. So what happens? The macrophages, they undergo transformation into the epithelioid and the Langerhans cells. These aggregate with the lymphocytes to form classical tuberculous granuloma. The normal lung tissue is lost and is replaced by a mass of fibrous tissue with granulomatous inflammation and it is characterized by the presence of large numbers of macrophages and multinucleated giant cells. There are numerous granuloma aggregate to form a primary lesion that is known as the Ghon's focus. It is a pale yellow caseous nodule, usually a few millimeter to 1 to 2 centimeter in diameter. So there are numerous granulomas that aggregate to form primary lesion, or it is known as the Ghon's focus. It is a pale yellow caseous nodule, usually few millimeter to 1 to 2 centimeter in diameter. It is characteristically situated in the periphery of the lungs. The combination of primary lesion and regional lymph node is referred to as the primary complex of Ranke. So there are numerous granulomas that aggregate to form primary lesion or the Ghon's focus. A pale yellow caseous nodule that usually a few millimeter to 1 to 2 centimeter in diameter. It is characteristically situated in the periphery of the lungs. The combination of primary lesions and regional lymph node is referred to as primary complex of Ranke. The lesion eventually calcifies and is clearly seen on the chest X-ray. So the lesion is calcified and is seen in the X-ray. The secondary foci in the other organism includes lymph nodes, serous membranes, meninges, bones, liver, kidney, and lungs. So the secondary foci in the other organs, including the lymph nodes, serous membrane, meningitis, bones, livers, kidneys, and the lungs. In the pathogenesis, the infection has occurred. It may be the appearance of the cell-mediated delayed type of hypersensitivity reaction. So there can be cell-mediated or delayed type of hypersensitivity reaction to the tuberculin. It is demonstrated by the tuberculin skin test. There are numerous granulomas that aggregate to form a primary lesion that is Ghon's focus. It is a pale yellow caseous nodule, usually a few millimeter to 1 to 2 centimeter in diameter, which is characteristically situated in the periphery of the lungs. The combination of a primary lesion and regional lymph node is referred to as primary complex of Ranke. The lesions eventually calcifies and is clearly seen on the chest X-ray. So there are numerous granulomas that aggregate to form a Ghon's focus and is a pale yellow caseous nodule that is usually a few millimeter to 1 to 2 centimeter in diameter, and it is characteristically situated in the periphery of the lungs. The combination of the primary lesion and the regional lymph node is referred to as primary complex of Ranke. The lesions eventually calcifies and is clearly seen on the chest X-ray. There is secondary foci in the other organs that includes lymph nodes, serous membrane, meninges, bones, liver, kidneys, and the lungs. Clinical features of pulmonary disease. The infection of a previously infected, that is tuberculin negative individual, is characterized by self-limiting febrile illness. So there is fever that is self-limiting. There are influenza-like illnesses like cold, coryza, headache. The skin test conversion is seen. You can see the primary complex, lymphadenopathy, consolidation, obstructive emphysema, pleural effusion, and erythroderma nodosum. So in the clinical features, because we will be talking only about the pulmonary disease here, so there will be infection of a previously uninfected tuberculin negative individual. The infection is self-limiting febrile illness with influenza-like illnesses. There is skin test conversion with primary complex, lymphadenopathy, consolidation, obstructive emphysema, pleural effusion, erythema nodosum. Now, the clinical features in case of miliary tuberculosis. In case of miliary tuberculosis, it is a blood-borne dissemination that is spreading by the blood. There are the characteristics of fever for 2 to 3 weeks with night sweats. There is fever for 2 to 3 weeks with night sweat, anorexia with no desire to eat, weight loss, dry cough. Chest X-ray has a classical appearance of fine 1 to 2 millimeter lesions that is known as millet seed. There is anemia and leukopenia that reflect the bone marrow involvement. So in the miliary tuberculosis, there is blood-borne dissemination with fever of 2 to 3 weeks, night sweats, anorexia. There is weight loss with dry cough. In the chest X-ray, there is classical appearance of fine 1 to 2 millimeter lesions that is known as millet seeds. Anemia and leukopenia, it reflect the bone marrow involvement. Next, we come to post-primary tuberculosis. In the post-primary tuberculosis, there is exogenous or new infection, or it can be endogenous, that is reactivation of the dormant primary lesion. So in the post-primary tuberculosis, it can be a new infection that is exogenous factor and endogenous, that is reactivation of the dormant primary lesion infection in a person who has been sensitized by earlier exposures. The most common, it occurs in the apex of the upper lobe, where the oxygen tension favors survival of the strictly aerobic organism. So it is most commonly occurring at the apex of the upper lobe, where the oxygen tension is favoring the survival of the strictly aerobic organism. The onset is insidious and it is developing slowly over weeks and several weeks. The systemic symptoms includes fever. There will be fever, night sweats, malaise, loss of appetite, and weight. So the systemic symptoms will include, we will have fever, we will have night sweat, malaise, and loss of appetite and weight. Other clinical features of the post-primary tuberculosis includes chronic cough standing for a long duration of time. With hemoptysis, there is pyrexia of the unknown origin, unresolved pneumonia with extensive pleural effusion. There can be asymptomatic diagnosis on the chest X-ray with weight loss, general debility, and spontaneous pneumonia. So the features of post-primary tuberculosis includes chronic cough with hemoptysis, pyrexia of unknown origin. It is unresolved pneumonia, exudative pleural effusion, asymptomatic that is diagnosed on the chest X-ray, weight loss with general debility, and spontaneous pneumothorax. There are certain radiological changes that could be seen with ill-defined opacification in one or both of the upper lobes. And as progression occurs, there is consolidation, collapse, and cavitation to a varying degree. So there is ill-defined opacification in one or both of the upper lobes. And as the progression occurs, there is consolidation with collapse and cavitation to a varying degree. Now we come to the extrapulmonary tuberculosis. There are certain clinical features of the extrapulmonary diseases, which includes lymphadenitis, that is an inflammation of the lymph nodes, gastrointestinal diseases. We have pericardial diseases affecting the heart, central nervous system diseases, bone and joint diseases, and genitourinary diseases. So the other systems are affected. That includes lymphadenitis, gastrointestinal disease, pericardial disease, central nervous system, bone and joint disease, and genitourinary system. The diagnosis is done by the unexplained cough for more than 2 to 3 weeks, particularly in the area where the tuberculosis is highly prevalent. And direct microscopy of sputum is done. Now, in the modern medicine, the therapeutics of tuberculosis is very vast. So we will not be talking about that, but we will be talking about the therapeutics of tuberculosis according to homeopathic perspective. This we are going to discuss in the next lecture. So this was all about tuberculosis. In the next lecture, we are going to discuss about the therapeutics or the most common homeopathic medicines that are given in case of tuberculosis for its management. So this was all for today. In the next lecture, we will be discussing about therapeutics of tuberculosis. This session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope the session is clear to you. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.